Okay, can you see my screen, Tejas? Okay. So very warm welcome to all. I'm Mahindra Mehra, MD of Sonoscape Medical Corporation, South Asia. We have a large number of participants at present, and doctors are still logging in continuously. On behalf of Sonoscape Medical, I thank each one of you for being partner to Sonoscape initiative of continued ultrasound education, especially with support and guidance of nearly all key luminaries and teachers of the country. Sonoscape Medical has taken a big leap in ultrasound industry by incorporating most advanced and innovative technology like artificial intelligence into our premium range of color Dopplers with deep learning algorithms and machine learning. Sonoscape AI-based ultrasound platform for wide range of clinical applications provide doctor with automation, simplification, diagnostic confidence, and most important, faster scans, which all of us will agree is the new norm as we face the invisible enemy of coronavirus. With the most futuristic hardware platform, Sonoscape color Dopplers support shorter scan time, less keystrokes, and higher accuracy. Built-in deep learning algorithm mimic the function of human brain and capable of learning and evolving with data with assimilation of big data. Sonoscape premium color Dopplers enable auto acquisition, auto identification of scan planes and anatomical structures, also facilitate auto outlining of suspicious lesions, borders, and its characteristics, along with auto annotate and auto measurement. S-Breast AI automatically outlines suspicious lesion border and reports classification according to BIRAG standards, provides standard reporting on classification of benign and malignant masses. S-Thyroid AI, the advanced tool which auto-detects and classifies suspicious thyroid lesions based on TI-RAGs, along with auto-reporting. The S-Fetus AI, fully automated and does accurate identification of significant planes and the fetal biometry based on deep learning and big data AI. So Sonoscape AI is most in-depth in the industry, covers wide range of whole body shared service applications for artificial intelligence. And obviously, Sonoscape Premium Color Dopplers fully loaded with all advanced features and tools and very full range of probes for wide applications. I'm just sharing few of the slides with the images which shows the strength of Sonoscape wide range of color Dopplers for different applications. Yes, at this time, this is the need. The whole machine, the color Doppler need to be fully automated at every step and every function, and that is what Sonoscape products are. This is the wide range of color Dopplers, both standalone and portable from Sonoscape. And now I'm very happy to now hand over the mic to Dr. Nidhi Bhatnagar, madam. As you know, she needs no introduction. She is the Vice President of MSK Ultrasound Society, and she is the principal consultant at Max Multispecialty Hospital. Please, Dr. Nidhi Bhatnagar, madam, please take the control.
Good evening and a very warm welcome to all who have joined today's webinar. Thank you, Sonoscape team, Mahindra, Gaurav, Jasmeet, Manoj, for hosting today's lecture. It has been a great initiative, and I'm sure that in today's times, where everybody is sitting at home, this would come as a welcome break. So to start with my presentation, in relevance to today's topic of discussion, ultrasound can be referred to as an extended stethoscope when present.
Madam, we can't see the presentation. Please share.
Oh, yeah. I'm so sorry. Okay.
Yes, ma'am. Yes, it has come full screen.
Yeah. Are we good here?
Thank you, ma'am.
Yeah, great. So we're talking of expansions and exciting applications of musculoskeletal ultrasound. And related to today's topic of discussion, ultrasound definitely can be referred to as an extended stethoscope when presented with musculoskeletal complaints of pain, swelling, loss of function, and deformity, if and when present. Today, my presentation is going to be a kaleidoscope of commonly presenting pathologies where ultrasound helps in the diagnosis. The rule of the thumb is, let's continue to widen our horizons. A frequently asked question every time there is a discussion on musculoskeletal ultrasound is MRI or ultrasound? And a very realistic answer to that is that ultrasound in MSK system is an imaging technique that adds a different and a complementary dimension to the traditional modalities of pain, a plain radiography, or computerized tomography, or MRI, whichever you may like, particularly in a country like ours, where there is an irrefutable constraint of resources in the peripheral regions. I'm sure you'll agree. So before I go on to the subject of today's evening, I am going to be saying a word on the new kid on the block, Sonoscape, our hosts of the evening today. Since their founding in 2002, Sonoscape has focused on innovating and developing medical equipment and are in the process of introducing something called as SMSK, which is an AI technology in their ultrasound systems. At the press of the button, one will be able to get the best frames, as you can see here. I hope you're able to see the marker here. And so to draw your attention to the images at the bottom, live scanning is followed by acquisition, giving the structure recognition, as you can see here, followed by automatic annotation. So as I say, what more does anybody want? On to our subject of today's discussion, starting with the ultrasound of the shoulder, since it is one of the most extensively researched regions by musculoskeletal ultrasound and is a fast, relatively cheap and dynamic way of examining the mother of all pathologies, the rotator cuff tears. As we all know, there are 4 tendons that make up the rotator cuff: the supraspinatus, subscapularis, and the conjoined tendon of infraspinatus, and that of the teres minor. Pathologies related to supraspinatus tendon are commonest, particularly of the rotator cuff tears. Now, the some signs referred to as are relatively echogenic tendon, fibrillar structure, and homogeneous. These are the hallmarks of normal tendon. Supraspinatus tendon, in addition, has a beak-shaped structure with a convex superior surface. Anisotropy is the biggest enemy anywhere in musculoskeletal imaging and is greatly pinching, particularly at the insertion of the supraspinatus tendon, where The artifactual hypoechoic changes when the angle of insonation is not perpendicular to the underlying structure, that is the supraspinatus that is being scanned, and hence the scanning needs to be meticulous in order to avoid the overdiagnosis of tendinosis, as is seen in this image here. There are many classifications of tears, and the most popular is that we have articular surface, bursal surface, or intrasubstance. In articular surface and bursal surface, again divided into partial thickness or complete. So the use of protocol-driven ultrasound of shoulder is important to ensure comprehensive and efficient evaluation. Rotator cuff tears can be classified according to the size. That means the small are less than 1 centimeter, medium 1 to 3 centimeters, large 3 to 5 centimeters, and massive greater than 5 centimeters. The first image is of the short axis grayscale scan demonstrating 1 centimeter partial thickness articular surface tear of the rotator cuff with intact bursal fibers. A diagnostic feature, that is a cartilage interface sign, also called as double cortex sign, is noted and is seen here due to the markedly hyperechoic line at the interface between the normally hypoechoic hyaline cartilage, which as you can see here, covering the subchondral surface of the humeral head, and a hypoechoic edematous supraspinatus tendon, which is showing tendinosis secondary to the tear of the supraspinatus. The next image is a long axis scan of the supraspinatus again, and is showing a partial articular surface tear at the footprint of the greater tuberosity, and it's associated with underlying cortical irregularity, which is quite diagnostic of underlying tear in case we are having a difficulty assessing whether this is a tear or a tendinosis. And this is also referred to as rim rent or PASTA, which is an acronym for partial articular supraspinatus avulsion. And the next ultrasound image is of the third kind of the tear of the supraspinatus, which is also called as the bursal surface tear, showing a well-defined hypoechoic disruption, which is extending from the bursal surface towards the greater tuberosity, and there is no connect to the hypoechoic underlying articular cartilage or the hyaline cartilage at the articular surface, and so it excludes the full thickness tear. Moving on to the next pain syndrome from shoulder region is that of the long head of the biceps afflictions. A very glamorous term was given to the bicipital tendinitis pain called as fasciitis, secondary to the trend of carrying large bags, which was introduced by the famous Victoria Posh Beckham. Now, the short axis scan here of the bicipital tendon in the bicipital groove is showing eccentric, significant fluid collection. A point of the border of bicipital tendon with the greatest effusion thickness was determined visually and was measured to be 2.1 millimeters. An effusion thickness around the bicipital tendon greater than 1 millimeters and a circumferential spread are the cutoff descriptors to differentiate between the physiological versus pathological bicipital tendon effusion. Now, one of the antecedent study indicated that simultaneous presentation of bicipital tendon with subacromial subdeltoid bursal effusion were indicative of rotator cuff tendon tears with a positive predictive value of greater than 95%. So the dislocations or effusions or tendinosis showing here because of the raised vascularity or hemorrhagic effusions, which was secondary to the glenohumeral dislocation, are other presentations causing bicipital tendinosis. Here is a video clip which shows short axis scan of the rotator interval, and the bicipital tendon is seen in the short axis, which shows the offending osteophyte, and this osteophyte actually went on to tear the bicipital tendon. The increased vascularity, which is surrounding the rotator interval, was of early adhesive capsulitis. Now, the static grayscale images on the right here, I'm just going to stop this for a minute. And the static grayscale images here are of the duplication of long head of the tendon in both long axis as well as the short axis scan. Now, cases of bifurcate origin of the long head of the biceps, as seen here in the actual case of the cadaver, it showed that this was an incidental encountering where through the diagnostic arthroscopy, and showed one limb, of course, to be taking its origin from the supraglenoid tubercle, and the other one to the posterior superior capsule. It actually spread along the posterior superior capsulolabral tissue and should not be confused with the tear of the bicipital tendon, as is seen here very clearly in the rotator interval. Another important structure which needs due respect is the acromioclavicular joint and its dysfunction. The joint is diarthrodial, which is with an interposed diarthrodial joint with an interposed fibrocartilaginous meniscal disc, of course not very clearly seen because here is a tear which is lying, and the joint dislocation with type 3 tear, in which the displacement of the clavicle, the lateral end of the clavicle, actually cranially gets displaced with reference to the acromion. And in this image can be seen very clearly, and it's a type 3 type of acromioclavicular dissociation where there is a cranial translation of the clavicle. Of course, other conditions such as degenerative condition of acromioclavicular osteoarthritis with loss of joint space, synovitis, and irregularity of the articular surfaces suggestive of early osteophytes can also be seen and can be one of the causes of pain and disability. Here is type 2 tear, as can be seen in this diagram, where there is no cranial translation or dislocation. However, there is a disruption, a complete disruption of the acromioclavicular joint, but the relationship of acromion to the clavicle is maintained. So to summarize, the structural changes in acromioclavicular dysfunction, which can be caught on ultrasound, are cortical irregularity along with the bony surfaces, narrowing of the acromioclavicular distance. Subchondral sclerosis cannot be seen on ultrasound, but subchondral cyst formation, capsular distension, and of course, hypertrophy of the acromioclavicular joint capsule can be seen with greater sensitivity as compared to the plain radiography. A Hill-Sachs lesion is a compression, fracture, or a dent of the posterior superlateral humeral surface that occurs in association with anterior instability or recurrent dislocation of the glenohumeral joint. Now, here is an example of the engaging lesion whereby there is a depression in the subchondral region. And why it's called engaging? Because the glenoid, the bony glenoid, actually gets engaged into the into the depression that is caused by the Hill-Sachs lesion. That's why it's called as a engaging Hill-Sachs lesion. And as you can see here, there is a complete loss of the contour on the dynamic scan as compared to, I'm going to stop this here, as compared to a normal scan, where you can see on the dynamic scan, there is a smooth contour of the humeral head, glenoid, adequate labrum without any eversion. What is more important here is that you can see there is a anatomical depression, which is along the posterior superior surface, and this is a posterior groove, and should not be confused for Hill-Sachs lesion, particularly in a symptomatic patient where probably will not be able to do a dynamic scan as freely as we are able to do here. Go back to the scan here, and you can see the depression, which is a big Hill-Sachs lesion with a depression and taking away the subchondral region as well. And the labrum is thickened and partially everted. This is a static scan, grayscale static image, again, of the normal sonoanatomy of the posterior shoulder. You can see the bony glenoid and the smooth cortical surface of the humerus over and above the conjoined tendon of infraspinatus and teres minor, as compared to the pathology here, where there was a nice grade 3 kind of Hill-Sachs. This is, of course, the bony glenoid, and reflected by the depth of the lesion, the defect in the articular surface down to the subchondral lesion was graded as grade 1 Hill-Sachs, Grade 2 was lesion which includes the subchondral bone minimally. However, the grade 3, where the lesion causes a large defect in the subchondral bone. Now, to illustrate significance of ultrasound in sternoclavicular joint evaluation, here's a small case for you where a 55-year-old lady, she actually came all the way from Aligarh and she was having a small swelling over the anterior chest wall and pain when she moved her hand or arm or did some work. Radiograph, of course, was absolutely normal, probably because of multiple overlying bony structures such as ribs, sternum, medial end of the clavicle. Now, because of the perception of synovitis by the clinician or a lump or a bump here, this patient was subjected to an ultrasound, which revealed this was ultrasound, and this revealed a cortical irregularity, lot of synovium, a little fluid here and on the color Doppler. There was raised vascularity. The capsular hypertrophy could not be very clearly seen because of the destruction. Before the needle was put in for aspiration, a CT scan was performed, which actually showed a soft tissue swelling here. And no mention of the sternoclavicular joint was made. However, there was an aspiration and small amount of tubercular treatment. Of course, the challenge was the differential diagnosis between rheumatoid arthritis, which sternoclavicular joint is probably one of the popular joints to get afflicted with, being a lady and that age group, and infective pathology, and we were able to give diagnosis. Now, the coracoclavicular ligament and acromioclavicular joint are two joints that work in sync with each other. And this is where they become the stabilizers of the entire shoulder joint. Acromioclavicular joint controls, as you can see here, and it controls the horizontal stability in anteroposterior plane, whilst the coracoclavicular ligament serves to control the vertical stability. Coracoclavicular ligament is composed of two parts, the conoid and the trapezoid component, which run from the coracoid process and go to the undersurface of the clavicle. Now, the injuries of coracoclavicular ligament are frequently associated with that of the acromioclavicular joint. Grade 2 is where there's disruption of the acromioclavicular joint. This is, of course, a strain, but minimal strain. There is a dissociation here, but the coracoclavicular ligament remains intact. And in the third grade, there's a complete disruption of the coracoclavicular as well as of the acromioclavicular ligament. And that's the reason why there is a cranial translation of the clavicle. Now, the grayscale image here is a very zoomed out image of the trapezoid component of the coracoclavicular ligament. I'm just going to stop this for a minute here. The video clips are of a young girl who was a table tennis player and had sustained an injury on an outstretched hand. No definite acromioclavicular injury was noted in the present scan. Now, this is a video that I'm going to share with you, and this is of the normal asymptomatic side, where I'm just going to go step by step and show you the anatomical planes. Now, this is, of course, the coracoid process, and cranially here, we can see the clavicle and the short axis. The interfacial planes, and what you see here, two hypoechoic regions are that of the coracoclavicular ligament. The trapezoid part, which goes posteriorly, is not very clearly seen. However, the conoid part is very clearly seen. As you can see, on circumduction, there was a good free movement of the joint. Now, if I start here on the symptomatic side, you can well see that there is thickening of the interfacial plane, and there is a thickening. The differentiation between the conoid and the trapezoid part could not be made very clearly. There is a thickening, and it seems as if there is a hypoechoic region which is trapezoidal in shape but not very clearly defined. And every time the patient moved the arm, as you can feel that there is a little pop or there is a little sliding movement or a jump of the clavicle over the coracoid process. So I'm just going to start this again, and you can well compare how you can see the conoid and trapezoid part very clearly here with a free movement, whereas here there is a restricted movement, thickened planes, and an ill-defined coracoclavicular ligament, which is not very clearly seen together. And of course, there's a pop or a sudden cranial burst of the lateral end of the clavicle. Now, glenohumeral dislocation is a common clinical presentation in emergency department, and recent studies and literature have demonstrated that there is a superiority of point of care ultrasound in detecting both anterior as well as posterior shoulder dislocations on ultrasound. Plain radiography has been the modality of choice for most clinicians. However, the challenge for the clinicians is in assessment of subluxations, which are painless and still allow the movement on passive manipulations. Now, this is a complication that happens with the hemiplegics with long-term morbidity because they land up with dislocations following subluxations, and these are inferior, not anterior posterior. And even after the neurological function improves, if there is not a good rehab that they have been subjected to, this results into long-term morbidity. Now, the acromio-greater tuberosity distance. I'm just going to help you familiarize with the sono landmarks here. The acromion or lateral end of the acromion, probe position goes in a long axis scan here in the lateral shoulder. So acromion, and we have greater tuberosity here. So that is the acromio-greater tuberosity distance. And acromio-greater tuberosity difference between the symptomatic and the asymptomatic side, and the S ratio have established themselves as strong markers in prediction of early subluxation. I'm happy to share one of the papers co-authored by me, which was published in Neurology India Journal on the same topic in 2019. Now, corresponding grayscale sonographic images show two cases of acromio-greater tuberosity distance. As you can see, this is the asymptomatic joint and asymptomatic joint, and on eyeballing, you can easily say that this distance, of course, has increased as compared to the asymptomatic side. And this is another case where, again, this is asymptomatic shoulder where the acromio-GT distance is within normal limits, which is 2.2 centimeters. Anything greater than that, which is like about 2.3 or 2.5 centimeters, say the inferior subluxation has started. ATGT distance should be less than 0.4 centimeters and the SS ratio 1.1 centimeters. And this is what is the carry-home message, that ultrasound in a hemiplegic should be in a protocol during the rehab to give an early indication if there is a subluxation that is about to happen. Now, high-resolution musculoskeletal ultrasound has been increasingly employed in daily rheumatological practice and clinical research. This method evaluates synovitis through grayscale, as well as a power Doppler study in defining synovitis, the activity in that synovium, and of course, the bony erosions. Now, presenting here is a simple algorithm for diagnosis of rheumatoid arthritis in early stages. The left upper grayscale image here shows a very mild synovitis without any capsular distension at the second dorsum metacarpophalangeal joint. So this is GSUS or grayscale ultrasound grade 1. On power Doppler study, there was no vascularity that was elicited in the synovium, and the power Doppler ultrasound was grade 0. So this patient can be either a stage 1 rheumatoid arthritis or maybe a patient of RA in remission. A review every month if it is stage 1 with follow-up with anti-CCP or MRI gives a definite diagnosis. Till then, the patients are kept on NSAIDs or steroids to reduce the inflammation as well as the pain and symptoms. This again is of established rheumatoid arthritis where we have mild synovitis and a capsular distension at the metacarpophalangeal joint, giving us a grayscale ultrasound grade of 2. And when the power Doppler was put on, we could see few power Doppler signals indicative of activity in the synovitis and the power Doppler ultrasound grade 1. Now, with a grayscale grade 2 and power Doppler grade 1, this is actually a marker for early RA, and the DMARDs or the disease modifying drugs should be started review every 3 months, and of course the drugs can be changed after 3 months if there is no response. In patients presenting with pain, in patients presenting with pain in the joints and doing an ultrasound, finding of a double contour sign here. This is at the first metatarsal head, and this one was at the lateral condyle of the knee joint, where there was a hyperechoic parallel irregular line to the underlying hyperechoic bony contours. This is of the lateral condyle and here of the first metatarsal, and in between is the hyaline hypoechoic articular cartilage. Not only the double contour sign, you could find hypoechoic to hyperechoic inhomogeneous material surrounded by small anechoic rim, as can be seen here, which is representing the two fascious material, and typical well-defined punched out cortical erosions, which are typically periarticular with overhanging edges, help to make the diagnosis of gouty arthritis on ultrasound very conclusively. And the treatment without performing a needle aspiration of an acute inflamed joint thus can be avoided. When tolerated by the children, ultrasound is a typical first-line modality for a wide array of pediatric musculoskeletal complaints. Again, I'm happy to share a new review paper with me as a primary author published in Indian Journal of Dermatology in 2019, sharing some of the structures which are well evaluated by ultrasound. The first is the grayscale ultrasound study of the wrist of a 2-month-old baby, showing unossified cartilages, as you can see here, which look like empty spaces when you do a radiograph of the wrist joint, and 2 ossific nuclei of hamate and capitate. The next scan is of a 5-year-old girl who presented with limping after having recently had upper respiratory infection. The ultrasound image shows here the anechoic fluid distending the right hip joint capsule, the growth plate, which is seen minimally, of course, the metaphyseal region, neck, and the diaphysis, and with the overlying iliopsoas tendon. Contralateral hip was also scanned at the same time for comparison, helping give a diagnosis of toxic synovitis. The next is a long axis scan of neonatal spine showing the dural layers, all of them, spinous processes, anterovertebral bodies, and of course, the conus medullaris here. Ultrasound image shows here of a 5-year-old child, a type 2 Salter-Harris injury at the lateral epicondyle, and a month-old baby here shows a breech delivery, and there is a coronal hip scan that was done. The alpha angle was 43.3 degrees. Appearance of the cartilage labrum was normal. There was no eversion there. An ossified femoral head was noted, and the triradiate cartilage was seen, but labrum, of course, was not everted, and the diagnosis of type 2C of DDH was given. Now, acute osteomyelitis. In acute osteomyelitis, I think ultrasound diagnosis was perhaps one of the earliest clinician validated pathologies. This 2-month-old baby presented with fever, arm pain, and swelling. The radiograph of the elbow was reported as normal. However, the long axis grayscale image showed periosteal thickening and the stripping of the periosteum with subperiosteal hypoechoic fluid collection, which was likely fluid. A diagnosis of acute humeral distal metadiaphysis osteomyelitis with subperiosteal collection was conclusively given, and retrospectively, of course, confirmed on the radiograph as well, where it could be seen that there was a periosteal stripping. This was, of course, the normal contralateral scan, which showed absolutely a normal periosteum and the underlying cortex. The olecranon bursa is a subcutaneous sac that overlies the olecranon process and contains a small amount of fluid to prevent against injury of subcutaneous tissues and the skin from uncovered bony olecranon, and is not visualized normally. Olecranon bursitis refers to inflammation of the olecranon bursa, and the right split screen image here shows a complex fluid collection in the olecranon bursa, features of synovial proliferation as compared to the normal interfacial planes on the asymptomatic side. Lateral epicondylitis, also known as tennis elbow, is an overuse syndrome of common extensor tendon and predominantly affects the extensor carpi radialis brevis, which is the deepest tendon. Frequency is 7 to 10 times that of medial epicondylitis, which is also called as a golfer's elbow. Now, thickening of the common extensor tendon, as seen in this long axis image, associated with hyperemia and diffuse heterogeneity, areas of focal hypoechogenicity are noted. There is often associated intratendinous calcification, as can be seen here, and irregularity of the tendon insertion on the lateral epicondylar region. The most common finding in patients with lateral epicondylitis, however, is the focal hypoechoic or anechoic areas, which in the background of intrinsic tendinopathy suggest intrasubstance tears with lateral epicondylitis. In imaging of median nerve, ultrasound is useful in examining carpal tunnel syndrome, potentially revealing in fully developed cases a triad of the palmar bowing of the flexor retinaculum greater than 2 millimeters beyond the line that connects the pisiform with the scaphoid, and flattening of the distal flattening of the median nerve distally with a proximal edema proximal to the flexor retinaculum. And last but not the least, an absolute CSA measurement, which is the cross-sectional area, should be between 9 to 11 millimeters square. Now, the lower images, of course, here show the bifid median nerve, which also is one of the causes of carpal tunnel syndrome, persistent median artery, and it has been said that the combined CSA is more sensitive a predictor of carpal tunnel syndrome than some of individual cross-sectional areas of both the components. With regard to ganglion cysts of the wrist, their sonographic appearance has been described as anechoic, oval or round, or lobulated. Now, these are most common soft tissue masses of the wrist and are composed of mucoid material surrounded by fibrous tissue without a synovial lining, which differentiates them histopathologically from a true synovial cyst. The non-compressibility and possible joint extension are other sonographic features of the ganglion cyst of the wrist. Now, the sagittal sonography shows here a 15 millimeter long anechoic ganglion cyst with posterior acoustic enhancement, lobular margins, and absence of septations. The lower images show exuberant tenosynovitis of the tendons of extensor compartment 4 with mild hyperemia, and this presented actually as a lobulated swelling on the dorsal of the wrist. Presumptively, clinically diagnosis was of ganglion cyst, which of course turned out to be tubercular. Rupture of scapholunate ligament causes scapholunate instability, which if untreated will eventually cause predictable patterns of osteoarthritis, also referred to as the scapholunate advanced collapse or SLAC. Now, the scapholunate ligament is a C-shaped ligament and has structurally 3 distinct parts, volar, membranous, and dorsal, but it is only the dorsal component which is clearly visualized by ultrasound. It should be 2 to 3 millimeters thick and not more, and the range of 2 to 5 millimeters length in the mediolateral expanse. The central scapholunate distance can be a good predictor of the disruption if present. Now, a strain elastography was performed for academic interest, and this is of the Symptomatic hand, you could see on a controlled grayscale image here, there is a thickening as compared to the normal asymptomatic one. And there was thickening, hypoechogenicity, and when the elastography was done, there was a softening that was seen in the scapholunate dorsal component as versus the normal side, a normal asymptomatic scapholunate ligament with a normal elastography with no softening. Now, each of the four medial digits has two flexor tendons, flexor digitorum superficialis and flexor digitorum profundus. At the base of the finger, the tendons enter a fibroosseous tunnel, which is formed by the palmar aspect of the digital bones and the fibrous tendon sheath composed of 5 annular pulleys and 4 cruciate pulleys that are interspersed between them. The fibrous sheath, that is the pulleys, play an essential role in preventing the anteroposterior or lateral divergence of the tendons from the finger axis. A2 pulley, right here, is considered to be the most crucial due to its significant load-bearing capabilities. Like, for example, as in rock climbers, ultrasound image here shows a complete tear of the A2 pulley in the smaller scan of the index finger with palmar dislocation of the flexor tendons. The space between the tendon and the proximal phalanx is filled with anechoic fluid. Also, there is a small fluid that you can see in the tendon sheath. The next image shows a complete tear of flexor digitorum superficialis, where it has torn itself and has completely retracted and is sitting at the level of I'm so sorry, this is a tear of the flexor digitorum profundus, where it has taken off from the distal phalanx, insertion at the base of the distal phalanx. It has completely gone and retracted and is lying against the A2 pulley right here at the level of the A2 pulley. And there's of course an emergent fragment that can also be seen. And this patient would definitely land up with Bhatnagar's deformity, where there will be a hyperextension of the distal interphalangeal joint and flexion at the level of the proximal interphalangeal joint, secondary to the bowstringing. Now, trigger finger is a kind of stenosing tenosynovitis of the flexor digitorum superficialis particularly, and at the level of A1 pulley. So we had the A2 pulley, which was seen in climbers and gets torn and gets affected, whereas trigger finger is seen at the level of the A1 pulley. Now, it develops due to repetitive microinjury from frequent flexion extension movements of the finger. Longitudinal and short axis scan shows a significant thickening of the A1 pulley with normally maintained flexor components and the volar plate here. Normal scan image on the left split screen image shows again normal components of the flexor digitorum superficialis, flexor digitorum profundus, and the volar plate with underlying cortex of the metacarpal. And it is of course flanked on either side by interdigital nerves and interdigital arteries. Now what you can see here is the pulley, which is going all around, and it's a flexor, it has fibrous sheath. Normally it is about less than 0.5 millimeters, but if it is greater than 1 millimeter, it can be called a thickened pulley. Dupuytren's contracture is characterized by two underlying lesions. One is the nodules and other is the cord, and these involve the palmar fascia at the distal palmar crease, especially starting from the distal palmar crease, especially involving the third and the fourth rays, with progressive disabling contracture. Compared to the tendons, as compared to the tendons here, these nodules are hypoechoic and typically hypervascular when they are acutely or short duration. When they are chronic, then they become isoechoic or they become echogenic, and the vascularity is not really seen here. Another image here of multiple palmar nodules that can be seen superficial to the flexor tendons in the palmar fascia. Glomangiomas, also known as glomerulus tumors, are benign vascular tumors typically seen at the distal extremities. Since they originate from the neuromyoarterial plexus, the pain is excruciating. To recap the solar anatomy of the nail and the distal fingertip, what you can see is a hyper-echogenic structure of the nail, a linear refractile sign, and underneath, of course, is the evenly spaced out subungual hypoechoic bed of the nail bed, and this is the subungual region, which is of course bounded inferiorly by the smooth echogenic cortical surface of the distal phalanx. Now, the gross specimen here shows characteristically a small and hypervascular. You can see the microvessels here on the surface, and it's a hypervascular nodule underneath the fingernail. And on ultrasound of this lesion, what we found was a subungual hypoechoic nodular lesion with hypervascularity on the power Doppler, and which was noted at the point of the maximal tenderness. A young lady presented with soft tissue swelling of the right palm, slowly growing. Bluish discoloration prompted the clinician to think that it could be a cavernous hemangioma and was sent for an ultrasound. There were no complaints of numbness or weakness of the hand. On ultrasound, a relatively hypoechoic, well-encapsulated multiple masses were noted in the deep palmar region surrounding the tendon, with no vascularity on power Doppler or distal enhancement. The surgical exploration of this led to the diagnosis of lipomas, and a little description about palmar lipomas. They can be superficial or they can be deep as in can be seen in the palmar space, and superficial are in the subcutaneous tissues. And they present with painless swelling, sometimes can attain very large sizes, even at the time the patient seeks medical attention. Now, the ulnar collateral ligament tears, they are common injuries which are involving, and of course the most popular is that of the thumb, also called as then the gamekeeper's thumb or the skier's thumb. They need a prompt and correct diagnosis, particularly if it is a Stener lesion, which is interposition of the adductor pollicis aponeurosis between the torn ends, and this needs a timely surgical management. Now, the left grayscale image is of the normal ulnar collateral ligament, where you can see a very well-defined, relatively echogenic ulnar collateral ligament with the overlying adductor pollicis aponeurosis. Symptomatic image shows thickening and inhomogeneity with a tear that is present of the ulnar collateral ligament, and there is no interposition of the overlying adductor pollicis aponeurosis in the hypoechoic cleft. The spectrum of sono signs of ulnar collateral ligament injuries can be strain, or they can be a partial thickness tear as seen here. They could be full thickness tear as shown in the diagrammatic representation here. There could be a bony avulsion which can be taken off and it can retract. There can be joint effusion, underlying wall or plate injury, or also a Stener lesion. Now, ultrasonography plays a fundamental role as a first-line imaging study of the intersection syndromes, which are non-infectious inflammatory conditions that affect that portion of the distal forearm, where the more common one, and this is called as a proximal intersection syndrome, where the tendons of compartment, extensor compartment 1, that is the abductor pollicis longus and extensor pollicis brevis, crossover or intersect over the tendons of the second extensor compartment, which are the extensor carpi radialis brevis and extensor carpi radialis longus. The more rarer one is of the distal intersection syndrome. So this is proximal, and this becomes the distal. And the distal intersection syndrome, where the extensor pollicis longus tendon crosses over, that is the third extensor compartment, crosses over the second extensor compartment. And this is, of course, again, called as the distal intersection syndrome. The grayscale images here show the proximal intersection syndrome, where there is distinct tendon thickening and tenosynovitis in form of little bit of infusion also, both of the first and the second extensor compartment, more of the second extensor compartment, as the tendons of the first extensor compartment are moving over the first one. The differential diagnosis, of course, has to be from de Quervain's disease, which is a pathological condition of stenosing tenosynovitis of the first dorsal compartment. And the pain syndrome is along the radial aspect of the distal forearm, as against the intersection syndrome, where the pain syndrome is at the dorsum of the distal forearm. The lower images, grayscale images, are showing the distal intersection syndrome, where the third extensor compartment contents, that is the extensor pollicis longus, is crossing over the second extensor compartment of extensor carpi radius longus and extensor carpi radialis brevis, both in long and short axis, and there is a minimal fluid that we can see in the second extensor compartment in between the two tendons. The next three slides show sonographic appearances of common disorders involving tendon, ligaments, synovial spaces, articular cartilages, menisci, and surrounding soft tissues of the knee joint. Now, the right upper sagittal ultrasound image is of the knee, showing joint effusion in the suprapatellar recess in between the two fat pads, which are the suprapatellar fat pad and the prefemoral fat pad, and this is an S-shaped space with mild suprapatellar effusion, but without the synovial thickening or synovial proliferation, as against an effusion here, which is again seen underneath the quadriceps tendon in the suprapatellar region or suprapatellar recess, not to be called bursa because it has a continuity with the joint space, and having a synovial proliferation of synovitis. Now, some unusual findings, say for example, the plica syndrome. Seen in the image here is the superior or suprapatellar plica with significant effusion. And plica syndrome is a term which is used to refer to internal derangements of the knee joint caused by the inflammation or injury to suprapatellar or medial patella or lateral plica, which are embryological remnants. Lipoma arborescens is a chronic, slow-growing intra-articular lesion of a benign nature and is characterized by villous proliferation of the synovium with replacement of the subsynovial connectivity of the connective tissue by mature fat cells, and it involves usually the suprapatellar pouch of the knee, as is seen here. Prepatellar bursitis, very easy and a very glamorous diagnosis, which is an inflammation of the prepatellar bursa. And prepatellar bursa is actually, in asymptomatic people, a virtual space in the subcutaneous tissues overlying the patella. It's also popularly called as the housemaid's knee, with marked swelling and can be tender to touch, but generally does not restrict the range of motion of the knee. Anechoic, well-marginated and oval cystic fluid collection is noted with thickened walls, and it is located superficial to the patella in this image, extending over the proximal patellar tendon. As opposed to clergyman's knee, a complex fluid collection is noted with internal echoes, and posterior enhancement is noted in distended superficial infrapatellar bursa. This is because it's seen over the distal insertion of the patellar tendon on the tibial tuberosity, which is showing a smooth cortical surface and contours. So as well can be appreciated, the presentation may be same. However, since the pressure points are different, the regions become differently affected. This is the prepatellar region, and this will be the superficial infrapatellar bursitis. Continuing with the knee, Meniscal evaluation is definitely suboptimal with ultrasound, but can assist in diagnosis along with other pathologies, which are medial collateral ligament tears or both the superficial as well as the deep components. Now, here in the left image is a normal sonoanatomy, which is showing the superficial component of the medial collateral ligament, and the arrows are pointing towards the deep component, which are the meniscofemoral and the meniscotibial components of the medial collateral ligament. The image on the right is showing the meniscofemoral tear right here, but the meniscotibial component is maintained, and there's a partial extrusion of the medial meniscus, not reaching up. Here is a tear of the medial meniscus, and the tear is actually the medial collateral ligament is both stringing over it and stretched over it. There is a partial tear which is not reaching up to the articular surface. Another image which is showing osteoarthritic knee because there are marginal osteophytes. There is a loss of joint space, and there is an extrusion of the medial meniscus and tear of both the deep components of medial collateral ligament, that is the meniscofemoral as well as the meniscotibial components. This, of course, is the proposition for evaluation of the meniscus all the way anteriorly and going circular all the way posteriorly to see both anterior and the posterior horns of the medial as well as the lateral meniscus one by one. Now, the anterior cruciate ligament draws a lot of curiosity, whether it can be seen or can be diagnosed on ultrasound. Well, it has two components, the anteromedial as well as the posterolateral bundles, and on ultrasound they cannot be differentiated. The diagnosis of anterior cruciate ligament injury has got a very high negative predictive value, but a low positive predictive value, since only a part of the anterior cruciate ligament can be seen, which is near the tibial side, and not the entire segment of the ACL. Here are the ultrasound images of normal ACL, which are showing hypoechoic rhomboidal kind of stripes, and they are seen between the two echogenic hyperechoic interfaces, that of the tibial plateau and of the intercondylar fat. In the symptomatic knee joint, which was done because the patient complained of injury as well as trauma and could not had a definite history of hesitancy whilst walking. ACL were not visualized clearly. If you can compare, this is an ACL which was seen of the tibial component, but ACL could not be visualized here, and this could have been a hematoma, or as compared to this one, this was a fibrotic tissue here, long-standing, along with an avulsed fragment, bony fragment. Three distinct indirect pathological findings for detecting tears of ACLs have been propounded, and they are hypoechoic lesion at the femoral insertion of the ACL, such as here, protrusion of the posterior fibers of the capsule on posterior scan, and S-shaped thickening of the posterior cruciate ligament. So that goes to prove that yes, posterior cruciate ligament also can be evaluated on an ultrasound scan through the popliteal fossa window. Now, moving on to something simpler, the diagnosis of a Baker's cyst, which can be well established by identification of a popliteal cyst, fluid containing neck between the tendons of the semimembranosus and the medial head of the gastrocnemius. A color Doppler view should always be obtained from the popliteal fossa in order to rule out any vascular pathology such as popliteal artery aneurysms. Baker's cyst has two components. The deeper is the neck, and the superficial portion is the bulbous or the body, and is subcutaneous, which ends in a rounded pole. Intracystic hemorrhage may be encountered sometimes in patients who are taking anticoagulants, as seen in this image with multiple septations, and loose osteochondral bodies can be also seen as hypoechoic echos within the Baker's cyst. Open fractures of the tibia with internal fixations are especially susceptible to non-unions. Now, according to a definition which is provided by FDA, a minimum of at least 9 months has to elapse since the initial injury, and there should be no signs of healing for final 3 months in order for us to say it's a non-union. That longer time is going to kill an orthopedician. Moed et al. Conducted a large prospective study which showed that ultrasound findings at 6 to 9 weeks showed that post-fracture have a 97% positive predictive value and 100% sensitivity in determining fracture healing in a patient with acute tibial fractures treated with locked intramedullary nailing. The above radiographs are at least 8 weeks apart to predict union. Well, who would want to wait for that much time if there is a modality available called ultrasound, which would give at 6 weeks the prediction of whether it's a delayed union, as seen here. This was at 6 weeks. A delayed union was given since there was no mineralization and reverb artifacts were seen from the implant or the intramedullary nail. The distance between fracture fragments was greater than 3 millimeters, as against a completely healed fracture, the bridging callus, which can be seen at about 8 weeks to 10 weeks. And this, of course, again, is a non-union and a delayed union because of the fracture fragments which are far apart and the implant being seen at 10 weeks. The images are reflective of ileosphoros bursitis in 2 patients scanned in both long axis as well as a transverse plane, showing a well-defined echo-free collection along the line of ileosphoros tendon and underlying normal femoroacetabular joint, which can be seen. Again, a short axis scan, and you can see very clearly that the cartilage is maintained, articular cartilage, and there is a collection which is present in the line of ileosphoros tendon. Versus another case where heterogeneous contents with homogeneous mid-level echos were seen in the region of the ileosphoros bursa and with internal septations. Ultrasound does have a higher sensitivity as compared to other modalities in diagnosing the septors. In this, I'd like to draw your attention to the irregularity of the acetabulum as compared to here. And this irregularity was erosive and destructive changes, which were secondary to the infective pathology and created an ileosphoros bursitis. Ileosphoros bursitis usually presents as non-specific anterior hip pain and can be due to a number of causes such as infections, snapping ileosphoros tendon, or post-hip arthroplasty. There are multiple bursae around hip joint. The ischio-gluteal, which is the largest bursa, ileosphoros, which can really grow large, and of course, the largest of all, the trochanteric bursa or the subgluteus maximus bursa. Now, the ischiotuberosity bursitis results in pain associated with trauma to the ischio-gluteal bursa or increased friction placed on the bursa from overuse of the hamstring tendons overlying it. A complex cystic mass superficial to the ischial tuberosity with smooth contours was seen in this patient with internal septas. Another case which was showing complex fluid with mid-level homogeneous internal echos, but on short axis grayscale study, there was suspect irregularity of the ischial tuberosity. Now the lower images are showing the evolution of perhaps this pathology into a complete destructive force. There was complete destruction of the ischial tuberosity with a complex fluid collection which turned to be tubercular. The first case here was a test case and a confirmed patient of spondyloarthropathy with typical findings of bilateral sacroiliitis on a radiograph. Ultrasound was done for academic interest and it showed bilateral widening of the SI joint with irregular subarticular interfaces, increased echogenicity, giving us a great lot of confidence to utilize ultrasound as a screening tool in patients complaining of low back pain. And we struck gold with the next case. This patient presented, I'm so sorry, and this patient, a 67-year-old male, presented with low back pain. And when we did a scan, we found a complex mass with synovitis, destruction of the ileum, and on color Doppler showing vascular signals. On biopsy, this proved to be underlying metastatic lesion, which is coming from the ileum and involving the SI joint. Diagnosis of sacroiliitis can be difficult to diagnose because it can be mistaken for other causes of low back pain. Ultrasound is an accessible imaging technique with a possible role in diagnosis of sacroiliitis and other pathologies which may involve, such as, of course, chronic osteomyelitis, one of them. Diagnosis of piriformis syndrome is through dynamic real-time scan, as will be shown in this video clip. Now, edematous piriformis due to fall on buttocks was noted to impinge on the sciatic nerve here in this patient. The contralateral exam of the asymptomatic hip joint, of course, helps in increasing the diagnostic confidence. And this is a video clip that I'm sharing with you, where the edematous piriformis triangular rhomboidal shaped small muscle was impinged on the sciatic nerve. Sciatic nerve has got three placements or positions with respect to the piriformis. And it is at this level where it is passing underneath the piriformis that the impingement occurs and the patient complains of a constant pain, which may be radiating into the gluteal region or down the thigh or maximal when the patient sits down. Anterior talofibular ligament injury is most common of the ligament injuries that can occur as a part of lateral ligament. Now, the normal anterior talofibular ligament is relatively an echogenic thin band which runs from the talus to the lateral malleolus and extends obliquely. Right upper image shows a thickened anterior talofibular ligament, whereas as compared to the normal asymptomatic side, which is also showing a comparative thickening. Now, the right this is, of course, the zoomed image of the symptomatic anterior talofibular ligament, which is showing edema and thickening of chronic changes. This is an acute full thickness tear of the talofibular ligament in a 27-year-old basketball player, and the retracted edges of the ligament are seen, very clearly visible. However, if these retracted edges are not seen, Drawer's test under real-time scanning can help distinguish between partial and complete tears of the anterior talofibular ligament, which have not yet retracted. Pathologies of Achilles tendon can be tears, tendinosis, peritendinitis, or Haeckel's. For partial thickness tears, there is often an enlargement, as can be seen here, and it's greater than 1 centimeters with abnormally hypoechoic or anechoic areas within, which correspond to a tear associated with surrounding tendonitis. Full thickness tear, which I'm going to share in this video here with you, and there they have separated edges, retracted edges, that's the proximal edge and that's the distal edge. Underneath is the Kager's fat pad, which every time there is a dynamic scan gets interposed between the retracted edges of complete tear of the tendoachilles, and the fluid is seen interposed in between the two, and this interposition of the Kager's fat becomes one of the indications for surgical intervention. The upper images are showing another pathology that afflicts tendoachilles, and that is called as Haeckel's syndrome, having some signs of the Haeckel's triad, that is insertional Achilles tendinopathy. You can see that the tendon is edematous and thickened, along with the retrocalcaneal bursitis and the pre-Achilles bursitis, which you can see at this level. Then, of course, there is called as the Haeckel's deformity, where along the posterior superior surface of the calcaneum, there are exostosis and erosive changes. The power Doppler study here shows hyperemia associated with tendinosis secondary to the microtears and the tendon degeneration. On sagittal ultrasound scan, the normal plantar fascia appears as fibular, relatively echogenic ligamentous structure. On ultrasound, plantar fasciopathy presents with thickening of hypoechoic appearance, as can be seen here, and thickened. 3 bundles are noted with mean thickness of the Lateral bundle is 2.3 millimeters, medial bundle of 0.6 millimeters. However, the most commonly involved in fasciopathy is the central bundle with a cutoff that should be less than 4 millimeters. Now, here is another case where linear echogenic foci were noted in the central bundle of the plantar fascia, and this was diagnosed as foreign body at one point of time. Exploration turned out to show that this was calcification in the plantar fascia, and one should be guarded against calcific plantar fasciopathy at the level of the insertion of the calcaneum. So on to a few ticklers. The occult fractures are greatly demonstrated and have a very great diagnostic accuracy through ultrasonography in both pediatric as well as in adult patients. Now, the first illustration is a case which had the radiograph reported as normal of the distal thigh. Uniquartal buccal fracture of distal femur metaphysis was caught on the ultrasound since the baby continued to be symptomatic and can be very clearly seen here. Now, another case where doubtful periosteal thickening along the distal medial humeral shaft on an elbow AP radiograph was seen, and this was confirmed as a callus, which was still organizing on ultrasound, sharing images of the occult fracture of the skull without any depression and undisplaced rib fracture validating ultrasound as a precious stone. Postoperative ultrasound evaluations in post-arthroscopic repairs of rotator cuff tear, as seen in this image, are able to localize the sutures and their anchors with their integrity very well, as opposed to where there is a failure of the implant or failure of the suture, as seen in this ultrasound image. Implants do not interfere with the image quality on ultrasound. Hence, the peri-implant fluid collections, whether complex or seromas, can be very well visualized and given out as a diagnosis. The implant alignments, which are very important post-arthroscopy, are seen here in the scan image, where you can see both the components, femoral as well as tibial, flush along each other and can be assessed on the static, but even better on a dynamic scan, where smooth, painless movement of both the implants of replaced joint can be documented. Now, post-implant evaluation, this is another case where radiograph as well as CT evaluation due to artifacts were unable to comment on the union of the callus formation of the radius. Visualization ultrasound was performed, and the visualization of all the screws and the plate with such clarity ruled out presence of any union or callus formation by ultrasound, and the patient was re-explored. So when we come to the lumps and the bumps, grayscale image of the left submandibular region in this young adult male showed an oval mixed echogenicity mass in the subcutaneous region with internal scattered echogenic foci with internal hypoechoic foci. So the echogenic foci were of calcifications and hypoechoic foci of keratin. Posterior acoustic attenuation was noted. Preliminary diagnosis of epidermal effusion cyst was made after this real-time scanning image. However, on histopathology, it was diagnosed as pilomatricoma. Five-year-old child presented with smooth-surfaced, very slowly growing, painless swelling along the inner surface of the tragus. Now, the grayscale image showed a well-defined circumscribed hypoechoic nodule and thickening in the subcutaneous soft tissues. Spectral sagittal color Doppler image showed high velocity and high vascularity with prominent draining vein and artery. In a study by Powell et al., it was stated that high vessel density with high peak arterial Doppler shift can be used to distinguish the hemangiomas from other vascular soft tissue masses which may need biopsy. in children, and this is a really important carry-home message because there could be a probability where a biopsy will be needed, and we will need to differentiate whether this is an atriovenous malformation or a very vascular mass, and we need to be careful on that account. Now, the nerve evaluation is a part of great functionality of the musculoskeletal ultrasound. Today, I wish to discuss an important entity, which is called as a double crush syndrome, which is distinct compression at two or more locations along the course of peripheral nerve that can coexist, and synergistically, they increase the symptom intensity. Hence, evaluation should be extended proximally going up to the root level. Now, this patient presented with a typical claw hand post-accident 8 months. Typical ulnar nerve involvement demonstrated a cross-sectional area at the level of distal cubital tunnel of greater than 9 millimeters square as compared to the right side. And the loss of fascicular pattern was seen on both the short axis as well as the long axis scan. The symptoms were unabating, and brachial plexus MRI was performed, which revealed compressive neuritis at the level of C7, C8 roots additionally. So, of course, this is a normal scan, and just to say that we can go up to the cord level and we can also go up to the root level in the brachial plexus analysis. This is, of course, we missed since the eye does not see what the mind does not know. Carrying on with the nerve descriptions, the first image is showing the ulnar nerve in the epicondylar group with a cross-sectional area of 9 millimeters square and loss of fascicular pattern, giving a diagnosis of neuritis of unknown origin. Now, the median nerve at the carpal tunnel here, which is seen in the short axis scan, and in the long axis scan, which is giving a cross-sectional area of 9.1 millimeters, well within the normal limits. This is an image of fibrolipomatosis hamartoma of the median nerve, which is a rare soft tissue tumor showing a coaxial cable-like appearance in the cross-section and a spaghetti-like thickened appearance in the longitudinal sections respectively. The next image is, of course, of the most common nerve sheath tumor called schwannoma, which is oval, hypoechoic, well encapsulated, with microcystic changes within and showing the nerve exiting as well as entering from it. It may not always be possible, though, of course, to differentiate between a schwannoma and a neurofibroma on ultrasound. Muscle injuries can be classified as extrinsic or intrinsic, as well as contusions and lacerations. The normal feathery pattern of bipendic muscle is seen in the first image. The central grayscale image is showing common muscle injury, which is also called as a tennis leg, where there is a tear between the medial gastrocnemius muscle and the underlying soleus at the level of myoepineurotic junction. And the echo signature of the muscle gastrocnemius has also changed. Seroma is filling in the tear where the tear is. Now, the grades of intrinsic muscle injuries are grade 1, which involves few muscle fibers within the bundle. Grade 2, the damaged fibers occupy up to 3 to 4th portion of the involved muscle, and of course grade 3 is where it involves greater than 3/4 of the damaged lesion. And this is, of course, one of the myoepineurotic extension or elongation injuries, as we call them. Foreign body localizations and extraction under real-time scanning is a real nice popular application of ultrasound. Formation of foreign body granulomas are a common sequelae. Plantar surface is showing here a metallic plantar surface with a metallic foreign body showing reverb artifacts on the ultrasound image. Now, scan of this gentleman who presented with discharging sinus on the extensor aspect of forearm and was most unwilling to give any kind of history, showed multiple subcutaneous splinters. This one, of course, is showing a foreign body granuloma at the site of the discharging sinus with granuloma formation. Muscle hernia is a diagnosis which should be considered in differential diagnosis in a patient with chronic pain and swelling if there is history of trauma with or without a fracture. Now, dynamic ultrasound is crucial in confirming the diagnosis and should be done on straining of the muscle, as is seen here, and This is the affected limb of right side, where on straining there was herniation of the tibialis anterior in a patient who came after motor vehicular accident and did not have a fracture, but showed a slowly growing swelling on the shin of the leg. Now, there was a facial defect that was demonstrated on dynamic scan of tibialis anterior muscle, through which tibialis anterior herniated and produced a focal bulge. The images here are showing absence of the superficial investing fascia or a buffer of subcutaneous tissue as seen in the normal scan. And of course, this is on a short axis scan where you can see a normal tibialis anterior, but on straining, you could see the herniation of tibialis anterior through the facial defect. Yet another case where there is a tear of the investing fascia, and of course there is a herniation of the tibialis anterior. Post-mesh plasty evaluation seen here after putting on limb mesh with wavy contours and echogenic sawtooth appearance on ultrasound for the complaints of constant pain, and this of course a normal look or a sono sign of the mesh. No evidence of seroma was found. There was no breach or tear of the mesh, and there was no recurrence of the herniation on abdominal straining. The actual thickness of the mesh is usually 10 millimeters, but in situ, it becomes greater than 2 millimeters, secondary to the soft tissue that envelopes it on both the sides. Now, this is a young girl, 13 years of age, presented with swelling and pain in the distal vertebral shaft and showed a relatively well-defined radiolucency, a thinned cortex on an AP ankle radiograph. On ultrasound, a cortical-based multicystic lesion was noted, arising from anterolateral cortex of tibia with elevation of the periosteum and a thin rim of echogenicity surrounding the mass. Presumed to be, of course, thin shell of the bone, which appeared intact without adjacent soft tissue mass. No internal vascularity was noted on power Doppler study. A diagnosis of aneurysmal bone cyst was made and confirmed on MRI. So ultrasound generally is not helpful in intramedullary bone lesions, as sound waves cannot penetrate the normal cortex, which is thick. But it can, however, readily identify the primary or secondary bone tumors where the cortex disruptions are there, or as seen here, the thinning of the cortex, which creates a helpful window to adequately insonate and help to give a diagnosis. Now, there was a patient who presented in emergency department with pain in the intergluteal region. An ultrasound was requested to evaluate the lump and define its exact margins. Ultrasound revealed a presence of 31 millimeters long, 7 millimeters wide, and a relatively well-defined oval-shaped hypoechoic area extending into the dermis from the deeper tissues. This was consistent, of course, with the abscess cavity, but more importantly, what it showed was some hyperechoic, hyperrefractile hair trap fragments, which was diagnostic of pilonidal abscess, which of course in olden days was also called as a Jeep disease. Young girl presented with periorbital cellulitis and swelling of the left side with a normal X-ray on ultrasound, a well-contained fluid collection with homogeneous mid-level echoes was seen, and this was, of course, was given a diagnosis, presumptive diagnosis of an abscess. However, what was more important was the lateral orbital margin, which showed a periosteal thickening and showed a cortical irregularity and a small erosion, and this was then labeled as chronic osteomyelitis, and the patient was lost to follow after the treatment. Now here is a wonderful article by Kok Meng Sun, which described all the anatomical landmarks of upper airways, including the vocal cords, the larynx, and of course the tracheal rings, and the cricoid membrane, thyroid cartilage, and cricoid cartilage. What made it very interesting read was how intubation can be made easy under challenging circumstances through ultrasound guidance. Now, the trachea gives a very typical bullet sign because of the distal shadowing, And in case of esophageal intubation, it becomes a double bullet sign as seen on the image here. Not that I would wish this on any anesthetist, however, it's a great point of care application of ultrasound to be aware of. Accurate assessment before and after interventional treatment for callosities, scars, or nevi demand a quantitative and non-invasive analysis of the depth, particularly where dermabrasion is being considered as a treatment option. High-frequency ultrasound can give the depth and the thickness of the lesion, as seen here in the callosity, the epidermal tissue invaginating into the dermis, the posterior wall of the lesion about 2.3 millimeters from the probe surface, a suspect keloid, which was ultimately turned out to be implantation dermoid, showed protuberant hypoechoic lesion with absence of any deeper extension, and a pigmented nevus here, which showed flat hypoechoic lesion confined to the epidermal layer, less than 0.5 millimeters in depth, with no evidence of deeper invasion or satellite lesion. The sonodiagnostic criteria to rule out melanoma in a pigmented nevus. So ultrasound has revolutionized management in musculoskeletal complaints. However, its application in neuraxial system has not yet enjoyed the same popularity. We started with the ultrasound of the shoulder, which enjoys by far the greatest respect amongst clinicians. I will end my presentation with ultrasound of the spine, which may raise a few eyebrows, but had very exciting results. This is an anterior transabdominal scan in a thin patient with access to D12 to L5 level only. Now, the axial scan through the IVD or the disc window showed following posterior neural structures and, of course, the spinal cord. Now, there was this comparison, which you can very well see and compare how well the image of the ultrasound turned out. Now, this is the comparative image through the intervertebral disc space and through the vertebral body. As you can see, the vertebral body casting acoustic shadowing, so the posterior neural structures are not seen, but this would be the scan plane for you to see if there are any destructive changes of the vertebral body, or there could be paraspinal masses. You can see the paraspinal masses through the intervertebral disc spaces again, and of course you can again see the spinal canal as noted. The dorsal nerve roots were also attempted to see, and we could not very clearly, but define the dorsal nerve roots bilaterally on a zoomed out image. And again, you can see a comparative here, which was we were close enough. The long axis scan, of course, showed the distance between the vertebral bodies and, of course, the intervertebral discs, where you could, of course, comment either on the osteophytes for the loss of the height of the vertebral bodies in collapses or extrusion of the disc spaces, and of course a normal scan. And last but not the least, we zoomed the spinal canal region and we were able to see the margins of the spinal canal, which could be predictive in if there is a lumbar canal stenosis, and of course we were able to see the spinal cord also inside. This, of course, is a comparative analysis of an MRI, not close enough, but yes, a try was attempted, and I hope that this was something that helped to create a carry-home message that let us continue to bring new applications of ultrasound in the times to come. Thank you very much for your patient listening. Over to him.
Yeah, thanks a lot, Dr. Nidhi ma'am, for such an informative and elaborate session today, covering wide scenarios and cases. We are getting overwhelming response. I think it's virtual house is jam-packed now. And some of the doctors have logged in some comments and questions.
Yes.
In the interest of time, yeah, ma'am, I'll just pick up a couple of them, the questions, and the rest we will take it offline and will inform the doctors later. So one of the question is from Dr. Jyoti Datta. It's like a general question. She is asking, suggest MSK ultrasound books to be read for beginners.
For the beginners, I think the best book would be John Jacobson. The um, the book is like, it would be a good read if you have your anatomy brushed up. So every time you want to go in for a chapter, for example, for shoulder, do plus brush up your anatomy of the shoulder and then jump on to the John Jacobson book. And of course, for advanced studies, she asked for the beginners, but for advanced, I think Martinelli, Marnix, Van Holsbeek, James Griffith, Eugene McNally, they're all wonderful authors and they have written fantastic books. You can pick up any one of those books of any of these authors.
Yeah, thank you, Dr. Nidhi. Another one is from Dr. Dvipen. He's asked how to characterize pediatric soft tissue masses on sonography.
Oh, that is a complete book in itself. And how to characterize on ultrasound, yes, of course, it's a basic principle for any soft tissue masses. You first need to characterize whether it's a solid or a cystic mass. If it is a solid mass, you need to find out whether it has vascularity or doesn't have vascularity, and what are the surrounding areas, what are the positions, the neurovascular bundles surrounding it. Then, of course, the most important thing in a pediatric patient is that if it goes in for biopsy, will it be an accessible biopsy or whether it need to go for an open biopsy? So the principles of ultrasound definitely remain the same. It's just that we are having a greater access and a comparative analysis with the other side. Sometimes there could be a probability, and I had a child, she came with swelling of the wrist on the dorsum, and she insisted that that was a swelling. And when we compared it, just because she was dominant right hand, every time she was moving the hand, there must be a pain syndrome there, which we could not elicit. But she had on the contralateral side exactly the same kind of bump, and we were able to really allay her fears that there was nothing there. So comparative analysis, Doppler analysis, and a dynamic analysis is good when we are dealing with the pediatric patients, and they take it very well. They absorb it very well. Their mom is there, and you can have a few gifts there. So you will be able to really put in all the functionalities of ultrasound in order to diagnose what we are dealing with.
Right. I'll take last question, and then rest we will reply to everyone later. This is a question from Dr. Ankit. I do not have a hockey stick probe. Can I still do MSK ultrasound?
Oh, yes, of course, Dr. Ankit. I'm really sorry. I can go back to my slides, and I'm going to show you something very interesting here where we were dealing with the glomus tumor. I should have mentioned, and we did this ultrasound with a normal linear probe 7 to 15 megahertz, and we are having it right here. So I'm just going to make it a full screen here.